Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.
Welcome to Remission Possible, the podcast dedicated to guiding and supporting you on your mission to achieve lower disease activity. We understand that this mission wasn't something you asked for, but remember, you are stronger than you think, and you deserve the opportunity to regain control and live your best life. In each episode, we'll share uplifting stories from patients succeeding in their mission, exploring how patients and doctors can collaborate to better understand the optimal course of treatment for various chronic conditions while keeping personal goals and lifestyle choices in mind. Today, we have an open and honest conversation with a leading rheumatologist about their motivation to help patients and how to collaborate with doctors to prevent subpar treatment. We'll discuss remission versus low disease activity and provide insights to help you better navigate your journey. It's time to rewrite your story because remission is possible. I'm JP Summers, patient advocate and community outreach manager at the Global Healthy Living Foundation and your host today. We're joined by our guest, Dr. Philip Mease, Director of Rheumatology Research at the Swedish Medical Center, Providence St. Joseph Health, and Clinical Professor at the University of Washington School of Medicine in Seattle. Thanks for joining us. Hi, Dr. Mease. We're happy to have you with us today.
Thank you very much, JP. I'm glad to be here.
I must say, Dr. Mease, as someone living with rheumatoid arthritis and migraine, I'm especially excited about today's discussion. So let's dive right into the episode with an important question. I want to ask, how do you define remission and low disease activity for your patients? And how do these definitions vary for patients? For example, for someone with axial spondylitis versus rheumatoid arthritis versus psoriatic arthritis.
JP, it's a very important question and something that has been evolving over the last several decades as we have developed and used more and more effective medications that can actually get a patient into what I'm going to define in a moment as true remission or low disease activity. Increasingly within rheumatology, now that we have more successful therapies, we are wanting to try to quantify where a patient is, what's their level of disease activity, and can we truly get them into remission? In the old days, when we didn't have effective therapies, we weren't paying so much attention to this. We were really just trying to get the patient to be as comfortable as possible and try not to cause too much damage or safety problems with any of the older therapies that we used to use. Now we're really trying to treat to target, and the target is either remission or low disease activity. So how do we define these? Well, I define these as clinical remission, imaging remission, and molecular remission or low disease activity on each of those levels. Clinical remission would be getting to a state where your symptoms of pain, fatigue, stiffness are essentially gone. And if we were to measure your physical function and your quality of life, those would be back to more or less normal. We will often accept low disease activity as being very close to true clinical remission. But I also mentioned imaging remission and molecular remission. What does that mean? So sometimes a person can have absence of symptoms, but when we do careful advanced imaging, say of joints or the spine, we find that there is MRI scan or ultrasound evidence of lingering inflammation in various areas. And so getting that to be gone would be getting a person into the state of imaging remission, as I call it. And then finally, there's molecular remission. And that would be if you go into a site of inflammation with, say, a biopsy needle of the lining tissue of the joint, or doing a skin biopsy and finding no evidence of cells or inflammatory molecules that are part of the pathogenesis of these diseases, that would be the ultimate goal of getting the disease completely gone from a molecular point of view. Of course, that's not practical to do, and so we really rely mostly on clinical and possibly imaging resolution as our goal of therapy.
Thanks so much for breaking that down for us. So that leads me to my next question. Can you please talk about how you measure remission in different types of chronic disease?
So, for example, a person with rheumatoid arthritis Their predominant issue is the painful joints and the physical dysfunction and impaired quality of life that arises from having painful joints. One measure that we use is something called the CDI score, and that's constituted by an assessment of the tender and swollen joints that the patient is experiencing at that moment. So that's physical exam as well as questioning. Asking a question about how their rheumatoid arthritis impacts them globally. And then there's a physician global assessment as well. And all these go into a numeric score. And there are various thresholds for what is remission, what is low disease activity, what is moderate, what is high disease activity. With psoriatic arthritis, there are more clinical domains that are involved. Besides painful joints, the patient will have psoriasis of their skin. They may have nail disease. They may have problems with their spine. And another area is something we call enthesitis, where tendons or ligaments insert into bone. Inflammation occurs in those places, like the Achilles tendon insertion. So with PSA patients, we have to have a broader set of questions that get asked, a broader physical examination, and then potentially broader imaging or laboratory evaluation to really understand whether the patient is in a state of remission or not. And there are several measures that have been developed for this, including something called the minimal disease activity criteria, which includes, for example, skin and enthesial assessment, or the DAPSA score, which is really focused a lot on joints, but also a clinical measure of inflammation called a CRP. And then in the ankylosing spondylitis or axial spondyloarthritis patient, there are a different set of questions. We're asking a lot about back pain, morning stiffness, patient global, peripheral pain, because they might have peripheral joints involved, as well as CRP. And all of these go into a measure called the ASDAS score, which has different thresholds. Now, you notice that I've been focusing a lot on these measures. And I suppose that's because I'm a measurement guy and I am really trying to quantify the patient's experience and get them to what I know is a low threshold. Why? Because we've done lots of studies that have shown that these low thresholds are correlated with really good outcomes, better function, better quality of life, less damage progression as we measure by imaging techniques. So all of these are really good.
Well, let's talk more about the patient and quality of life. How do you incorporate their personal goals into the treatment plan while also striving for low disease activity or remission?
So the patient may come in with a completely different idea about what is remission or low disease activity for them. Getting into remission may mean being able to go to their son's soccer game, or it may mean being able to do some manual work that is part of their job that they couldn't do before. So there might be completely different targets of treatment that the patient may have. I also want to know, what do you want? What is your goal? What would you most like to regain in your life? And this may be something as simple as what I mentioned earlier, getting to their child's soccer game. Or it may mean, for example, less vulnerability about the future. When I'm truly in a state of remission, will I not have disease flares? If I'm truly in a state of remission, can I decrease my medicines so I'm less worried about side effects? Will my family grow tired of the fact that I'm in pain and not able to do functions with them? So this all needs to be woven into the discussion about what true remission or low disease activity is. The root of all of this is education and really having shared discussion about what the patient is feeling and what the physician is observing, both by questioning the patient and examining the patient, and then sharing that and saying, okay, we can expect to have improvement in this area, but maybe not in this other area. And so we have a more realistic idea of what is going on each time we visit.
You know, I'm so thankful for the open and honest relationship I have with my own RA specialist. So let's talk about shared discussion. How can doctors ensure that they're not just looking at clinical measures, but they are also taking into account the patient's personal experience with their disease?
So it's important to step away for some time during our visits from these measures and to what's the patient experience? What is going on with you? How is the disease impacting you? Is it causing you to feel depressed and anxious? Are you not able to do important things with your family? And making sure that you're weaving all of that discussion into the ultimate decision-making about, are we okay with keeping therapy as it is? Or do we want to move on or change therapy approaches in some way or another, or bring other resources to bear? For example, if a person has, as part of their axial spondyloarthritis condition, uveitis, an inflammation of the eye, then we need to know about that. We need to hear about it from the patient and then make sure that that's being adequately treated, or bringing an ophthalmologist into the picture. In the patient with psoriatic arthritis, there too, there's teamwork that needs to go on, working with the dermatologist, maybe a physical therapist who is helping the patient with non-medication approaches. So keeping really open to the idea that there's a village of healthcare providers that may make the experience more optimal for the patient. So, JP, let me turn the table on you and ask, what are some specific markers or milestones that are meaningful to you for achievement of remission or low disease activity?
I can vividly remember there was a follow-up appointment with my rheumatologist where I walked into the exam room feeling the best I ever had since my RA diagnosis, which was 2 years prior, I believe. My specialist immediately noted I did not once have any issues sitting down or getting out from the chair. And I told her I woke up the past 3 months with my body allowing me to shower, reach for items in the kitchen, even put dishes away, prep for meals. And I'd have to say the other obstacle that was challenging was the door handles. I was able to open the door without difficulties. Both of us smiled, but I can tell you, my smile was so much bigger than hers. Just for the simple fact that, again, the treatment regimen was finally showing some positive results. And I just couldn't wait to get home and share that news with my kids and let them know that it's important for me to be present for their school events and just to enjoy the day out with them.
That's terrific. I really appreciate hearing that story, and it really illustrates well how important certain life activities are. Being with your family, being able to do simple things like getting out of bed and getting right into the shower and moving into the day. So I think that that's such a sign of, yes, that should be part of our definition as well.
Absolutely. Being able to share those things with your doctor is so important. Let me ask you, Dr. Mease, how can a doctor and patients establish a relationship of trust and openness?
So I think the most important thing is openness. So for there to be enough trust, friendliness, kindness in the doctor and patient relationship that the patient can feel increasingly comfortable over time to be completely open about all that they're experiencing and transmitting that, to communicate that, and have the time in a visit to do so. I know that sometimes this is hard because if the clinician has a certain time limit to their new patient visit or follow-up visit, that's a constraint. But I hope that, especially with rheumatic disease patients, we get to know people over time, that ultimately this kind of really open relationship can occur. And I think where advocacy groups can have a role is to teach patients about that to say, really be candid with your physician. Let them know what you're experiencing and feeling. All that goes into their thinking as they're going through making assessments of the disease, and also kind of setting appropriate expectations. For example, when you start a new medication that's injected or infused, it's kind of scary. And wow, this seems very big deal. All of a sudden, I'm injecting something into myself. But then it turns out that over time, it can really work. But the patient needs to know, hey, it may not work right away. It may take 3 months before the effect really starts to begin to be apparent. And so all of these things are things that can be learned and appreciated with not only discussions with the physician and their nursing staff, but also the patient advocacy groups, which are such an important contribution to the care of our chronic immune patients.
First off, I will say Having an open and honest relationship has been so crucial in my treatment journey. And there are times I feel that maybe I'm constantly nudging the nurse, asking more questions, but it's essential to discuss every physical obstacle and not to forget the emotional impact that your limitations can cause. And it's often debilitating. And your medical provider needs to know all these details. Whether you're scared about starting a new infusion, I hate needles. I absolutely hate them. But just knowing that I have the reassuring of my medical provider and their staff to kind of guide me through that process. And again, it's just needing to have that honesty. And when you get your provider to help you understand things, it is so huge. And being a patient is something that I've learned over the years. It doesn't get any easier, but it also doesn't get any harder. It's just about finding the right balance. And I feel that I found that balance again with just having that discussion, being able to ask questions and know that they're going to listen and they're going to guide me in the direction I need to go. As a patient, I can tell you firsthand how important it is to work together as a team to achieve remission or low disease activity. It is so easy to feel discouraged and even hopeless. Can you speak to the importance of having a doctor who is invested in our journey and how that can give us hope and motivation we need to keep trying new therapies?
So I think it's very important for the trust building aspect of the doctor-patient relationship or the nurse practitioner or physician assistant and patient relationship. By the way, I just want to emphasize that increasingly advanced practice practitioners like nurse practitioners are an important part of rheumatology care in this country and play a very important role in that trust building process. So many patients with chronic autoimmune disease will have depression, anxiety, and other emotional burden from the disease. They are less than what they used to be in their own eyes and mind, and they're really feeling vulnerable. They're concerned about being a burden to others in their family or in their workplace. And so there are huge social and emotional costs when you have these diseases, and especially if you're not in a state of remission or low disease activity, if you have subpar experience with your therapies. Just think about what you described earlier. When you suddenly, not suddenly, but gradually realize, hey, this treatment is really working for my rheumatoid arthritis symptoms. And the smile, you described the smile that went all the way across your face. And that is so important to achieve that level of, oh, there's light at the end of the tunnel. Oh, I can get my head above water after plunging into the lake and being down there in the dark. And I'm suddenly breasting above the water line and getting a big gulp of fresh air. And I feel that these moments, and especially if we can get them to be most of the time, that's such a important goal for us so that you can break out of the cycle of, oh, I'm diminished. Oh, I'm feeling depressed and lonely and anxious. That's so important. And working with your healthcare team to achieve that is, I think, very important.
I just have to say, Dr. Mease, I love that head above water analogy because it really does feel like you're sometimes drowning. And with the symptoms, that perspective does make so much sense. So, you've touched upon the social and emotional costs for patients who experience subpar treatment, which is an important aspect to consider in their overall well-being. Another critical component of patient care is evaluating treatment options. So, let's discuss the potential risks associated with switching therapies when current drugs aren't working. How can patients and doctors work together to make the best decisions for each individual case while considering these risks?
The biggest risk has to do with the hopefully brief period of time when a person is starting a new treatment, and we know it may take weeks to months before it really kicks in, and then leaving behind a medication which either wasn't working or maybe was working some, but just not adequately. So there's a period of time where they've lost that benefit from the previous medication, even though subpar, trying for something better going forward, but there's that little lag time. So that's something something that we try to bridge with maybe a little use of prednisone or anti-inflammatory medications. I think also just making sure that the patient is aware that that could occur. Then, of course, it's important to educate the patient about potential side effects that can occur. So I think those are probably the main ones. The period of time of waiting to see if you're going to have an effect and any new risks that might be associated with that new therapy. But if we're good and can achieve a better state of treatment with the new treatment, then that's what we're aiming for.
Before we conclude, our other guests on the podcast that you may have heard in episode 1 and 2, Jed and Natalie, both have a question for you. Jed, go right ahead.
Hi, Dr. Mease. How do you best manage patients who feel they've reached the end of their treatment when nothing seems to work anymore, or who have had severe reactions to NSAIDs and biologics?
Jed, thanks very much for asking that question, because it's one that we face on a regular basis with our patients who have been around the block many times with many different therapies. So as you know, we have multiple medications that we use in the treatment of our various diseases. We do find that some patients may have tried virtually everything, yet they break through and start to have more issues going on. So there's various things that we do. One is, of course, to consider any of the medicines that haven't been tried in one of those classes. Now, that may only get us so far. And one of the things that's starting to occur is we're starting to see combinations of treatments. So adding together two different classes. This is getting more toward what is being done in cancer medicine, where you bring to bear sometimes 2, 3, 4 medications, each working in a different way to get rid of the cancer. And so we're applying these same principles in rheumatology. And I think we're going to see more of this in the future. One key point is that we need to establish the safety of putting these medicines together. Obviously, if by putting two together, you get more serious infections. And so we need to make sure that when we're doing this, we're really establishing that there's not a loss of safety when we are intensifying treatment in this way. So I think between trying medicines that haven't been tried before, trying combinations of medicines even when they're off-label, and then the other, of course, is to make sure that all the symptoms that the patient is experiencing are due to the autoimmune disease. Sometimes there can be other factors involved, like, as I mentioned earlier, if the patient has osteoarthritis in certain joints, that's not going to get better with the immune moderating drugs that we have. And also there is the condition fibromyalgia that we mentioned earlier, where if that's coexistent, then using specific treatments for that is in order. So it means having an open mind, open inquiry, and just being willing to try.
And now we have a question from our other guest, Natalie. Natalie, go ahead.
Hello, Dr. Mease. What do you tell a patient who is scared to try new therapy or hesitant to switch because they're feeling fine?
Thanks, Natalie, for asking it, because it's really, again, very common issue that we face. So let's start with the person who is pretty new to the disease that they have been diagnosed with and are very new to the treatments that we use, especially the injected or infused biologic medications. So one of the things that I will do is ask the person, do you have a friend or relative, a coworker, who is on one of these medications? And it seems like people know the names of these medicines. People will say, of course, I've seen the TV advertisements. And so they have a little bit of a knowledge about it. But importantly, if they have a friend or neighbor, I will say, how has their experience been? And if their experience has been good, for example, if Aunt Sally has said, boy, this changed my life, I'm now able to get back to function and I've tolerated the medicine pretty well, that's helpful, because then I will encourage the person I'm working with to say, go and talk to Aunt Sally more, hear more about her experience with it. What's it like to give the injection for the first few times? I will often say, hey, this is a big deal. It's scary to have a new diagnosis like this. I've talk to you about medicines that you may really be worried about, I encourage you to step back. Don't make a decision today. Go home, think about it, talk about it with your family, do some reading and learn more about these treatments, hopefully from reputable sources on the internet, and make a reasoned decision that you are comfortable with. Because the worst thing in the world is for you to feel like you're being pushed or pressured into trying something that you're nervous about. So this is a way of gradually increasing trust between you and your practitioner. The other thing you mentioned was, Natalie, was having to do with switching medications and some of the concerns and issues around that. And that's a bit of a different issue because you've already started to experience what it's like to be on a biologic medicine that you inject. And so it's more just the unknown of what this new medication may hold for you. Will it be as efficacious or more efficacious? That's what we're hoping for. Will it be as safe or safer? Again, that's what we're hoping for. Behind that, you're worried. Will it not work as well? Will it create some new safety issues for me? So again, that conversation with your clinician, what's been their experience with the medication? What have the experience of others who have switched to that medication been like? Having these types of open conversations and again, establishing trust with your healthcare team. That's so important.
We're hoping lots of fellow patients hear this podcast. Dr. Mease, I'm a patient about to embark on a long journey figuring the best treatment for me, or maybe I'm a patient trying not to be discouraged. If you had 3 words to share with me to give me courage to continue on as a doctor, what would those words be?
They would be hope, trust, and confidence.
I love them. What a great way to conclude this episode. Thank you so much, Dr. Mease.
And thank you, JP. I really enjoyed this.
And I will tell you, if I were to walk into your office as newly or, been diagnosed for several years, everything you said just resonated so well. And I appreciate that. I appreciate the work that you do. So thank you.
Well, and thank you for what you do very much.
And to our listeners, thank you for joining us on Remission Possible, the podcast where we explore the path to low disease activity and improved well-being. We hope the stories, insights, and guidance we've shared have inspired and empowered you along the way. This podcast was made possible with support from AbbVie US. If you like what you've heard, be sure to rate our podcast, write a positive review, and spread the word by sharing with your friends and family. It'll help more people like you find us.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.